This meeting is being recorded.
Okay, so thank you everyone for joining us today. My name is Zoe. I am the branch manager at our Washougal branch for Fort Vancouver Regional Libraries. We're just going to have a presentation today, and we'll have some time at the end for questions. So if everyone can mute themselves and wait to have your questions at the end, we should have some time for that. Again, this presentation is being recorded, so you're welcome to have your video on or off, whatever you prefer, and a recording will be up on Fort Vancouver Regional Libraries page, probably in a few days up on our YouTube page. So I guess without further ado, I want to thank Ripple Wellness and Dr. Kellie Moore for being here tonight. And Dr. Kellie, I'm going to hand it over to you.
Sounds good. Thanks, Zoe. And thanks everyone for joining us tonight. I'm just going to share my screen and we will dive into it. Let's see here. All right. I think that looks good. Okay. All right. So yeah, we're going to be talking about menopause tonight. It's a big topic. We've got lots to cover. So let's get started. And why can't I do this? Okay, there we go. Before we get started, I need to change something here. There we go. I want everyone to just keep in mind the intention behind this talk. It's not about leaving with kind of a list of shoulds or things that you could have done better. This is really the goal is for this to be an inspirational talk, for you to really feel empowered about your health when you leave this talk. Also, it's important to note that while I am a physician, I'm unlikely to be your physician, at least not yet. And this information is really just for educational purposes. It shouldn't be considered medical advice. I'll be planting a lot of seeds about things you could talk to a medical provider about. And also giving you a lot of information of things you could safely incorporate on your own. I just need to ask, so maybe, hold on one second. I see this like a little bar on my screen. Does anyone else see that? Zoe, do you see that? Can you see my full slide?
I just see a white screen right now, so I'm not seeing anything on your slide.
You don't see any?
That's what everyone else is in the chat is also saying.
Okay, when I shared my screen with you before, were you able to see the slides?
No.
No, I just saw your shared screen and then it went away.
That's weird. Okay, I'm gonna stop sharing. Get started again. Navigating, share. What is happening? All right, let me try this again. Can you see this? Participants cannot see your application.
I can see it, yes.
Yay, okay.
Can we have some confirmation? Can anyone else see it?
Okay.
I saw it for a second and now it just says loading. So before you put it into presentation mode, I think I saw some Google Slides. And now I just see a black page that says loading.
What do you see, Zoe?
Yeah, I was seeing your slides and now I just see the black page as well. Let me see. Let me take a look here.
This is my screen sharing. Hold on. I have not had this happen before. I share my screen all the time without trouble. Let's see. It says my screen sharing is paused. Am I so I have all the access I need to share my screen, right?
Yeah, you're a host, so you should be fine, but let me double check in here.
Okay. Share screen. Navigating menopause. Can you see it now?
Yes.
So it
So
only
it only
it changes when I push slideshow. Is that what's happening? Like if I go like
if I go like
Oh, no, now I can see as you change your slides.
you
I
can see all
can see all
that.
of that.
Yeah.
Let me see what
Let me
happens when
see what
I
happens
push.
when I push.
Does it go
Does it
away?
go away?
Yeah, now it's just loading.
Okay.
Okay.
Well, that is weird. And it says I'm getting a little, okay. I'm getting a little orange flag that says your screen sharing is paused. I don't know why it's doing that. Zoe, can you just see if you stop record? Because it's also giving me the little recording sign. I don't know if that shouldn't make a difference though. Okay. You know what? I think I'm just gonna move through the slides without like on the, hold on one sec. Let me try. I think I'm just gonna have to do something different. Hold on. I'm just gonna have to make this slide big and share it that way, which is annoying, but okay. All right, let's try this. So you guys, you can all see this, right?
Yes.
Okay, well, we're just gonna work with it. Okay. I don't know what's happening. All right, so this is going to be a little bit awkward, but hopefully you can all see the most important. There just have a couple images that are important to see, but mostly I'll just be talking. So I'm a naturopathic physician at Ripple Wellness, which is a clinic in Washougal. I'll talk more about what it's like to work with a naturopath for those of you who haven't before worked with one, but I focus on preventing and treating chronic disease, including digestive, hormonal, and metabolic disorders, using primarily lifestyle medicine as well as other tools. Ripple is a disciplinary clinic in Washougal. If you haven't been there, we have a lot of different offerings, not just naturopathic medicine, but acupuncture, massage, nutrition, mental health counseling, and also breathwork sessions. We do regular community classes. So if you want to stay in the loop and do more of these classes, put your email in the chat and we'll add you to our list. So tonight's outline, we're going to start with understanding menopause, and then we're going to talk about using lifestyle to smooth the menopausal transition. We'll talk about different options for symptom support, and then what concerns come beyond menopause, concerns and opportunities, and then opportunities to dive deeper into this information. So understanding menopause, let's start with some menopausal misconceptions. And as a scientific community, we're just really starting to learn more about menopause. We're always learning, and a lot of our learning comes not coincidentally with more and more women in fields like science and medicine. So that's important to acknowledge. Back in Hippocrates' time, in around 450 BC, Hippocrates was considered the father of medicine. And at that time, he classified menopause as a climacteric syndrome, a time when women were losing power and not much use to society, which we'll see later is totally wrong. It wasn't until the 1880s when it was recognized as a medical condition, but it was described as the death of the womb. A lot of the language around menopause is very negative and also very much focused on a woman's reproductive capacity. Freud argued that menopause was a neurosis caused by lack of hormones. And even in the 60s, when we started to learn more about menopausal therapy, there was a prominent gynecologist and author who was an advocate of supporting and offering women menopausal hormone therapy, but it was really from a male perspective of giving every woman the right, indeed the duty, to counteract chemical castration so that they would be more sexually generous and easy to live with. This kind of misogyny in science and medicine has percolated down into how women are cared for today, even by female providers, because we don't learn nearly enough about menopause in medical school. And does it really matter the medical school that you go to? I include mine in that statement. We only had maybe a lecture on what's really a complex topic that affects 50% of the population for a significant portion of their life. So it's not enough information. And then on top of that, providers are often uncomfortable talking about perimenopausal symptoms, and that also bleeds into just being uncomfortable talking about sexual health in general. Menopausal symptoms are often considered less important and also less lucrative. That may not be coincidental than other gynecological conditions that require procedures. And women are essentially just expected to, and themselves expect, that menopause and perimenopause is a time that they're going to just going to have to suffer. So what I see, part of my role as a physician and as a female practitioner is to really normalize this very natural process. Menopause is not a disease, it's just a time of hormonal transition. So just like we don't consider prepubescent children, girls, to be diseased, we don't consider postmenopausal women to be diseased. It's just a change in our hormone levels, but it's not a dysfunction. It's not a disease. Nearly 40% of a woman's life, if she lives to the average life expectancy in this country, is going to happen after menopause. And this is a time, the perimenopausal period, which we'll talk more about, is a time of physiological flux. And as such, it's a really critical, important window for health. This means that minor health issues that you maybe were able to kind of paper over premenopausally become amplified, more problematic, and potentially permanent. And then conversely, it's a time when we can make small lifestyle changes that can pay huge dividends in terms of our long-term health. So it's an important time to pay attention to your body. Menopause itself, this word menopause, we're using it as kind of an umbrella term, but its true definition is really kind of a line in the sand. It just says host disabled participant screen sharing.
Okay, sorry. Let me go back. I apologize.
Oh, somebody was giving us.
Try again.
That's when you see this area restricted. Hey, Zoe, do you see this message here from Jessica Sand? It seems like she might know what's happening. I'm not really sure. There may be something to disable a screen sharing. Ensure that disable screen sharing when guests are in the meeting setting in the web portal settings page is disabled. I don't know what that means, but anyway, we'll just try again with what we were doing. Okay, can everyone see this now? All right, let's keep going. Let's keep plugging along. Menopause marks the time at which you have not had a period for 12 consecutive months. In this country, the average age is 51 to 52, but any time between 45 and 54 is considered healthy. Interestingly, the average age of menopause is not affected by the age that you started menstruating. It's not about the number of menstruations that your ovaries are capable of. It's more complex than that. Let's tease apart natural versus induced menopause. There's no sort of like good or bad. These are just different ways that menopause can happen. Natural menopause is caused by loss of follicular activity in the ovaries, usually, but not always, due to aging. Sometimes we have premature menopause, and we'll talk about that in a minute. That's also a type of natural menopause, but it's not due to aging. It's due to another type of process. Then we have induced menopause. This is as a result of a medical procedure like surgery or a medical treatment like chemotherapy that's resulted in removal or damage to the ovaries, and they're no longer functioning. Timing matters when it comes to menopause. There's kind of a Goldilocks zone of amount of time you want to have exposure to estrogen. Too little estrogen exposure over a lifetime, and you have increased risks. And then too much estrogen exposure has a different set of risks. So we have different timings and different health considerations with those timings when it comes to menopause. So premature menopause is when you have that final menstrual period, that last period before age 40. This is considered premature, and there are sort of more forceful medical interventions that could potentially be taken at this time to give your body prolonged exposure to estrogen, so that you don't have you can mitigate the increased risks of osteoporosis, cardiovascular disease, etc. Same with early menopause. When you have that final menstrual period before age 45, that is considered early. It doesn't mean that we try to restart the cycle or try to figure out why are you going into early menopause, but it does mean that you are at greater risk for those postmenopausal health concerns like cardiovascular disease, osteoporosis, and dementia, and that you might benefit from using menopausal hormone therapy to mitigate those risks. And then conversely, late menopause, you're gonna, if that occurs after age 55, this is associated with increased risk for breast and endometrial cancer, those risks of excess or prolonged estrogen exposure. Again, a conversation you'd want to have with your medical provider. So we have another way of kind of breaking down the phases of a woman's life around her menstrual cycles. There's the premenopausal phase. This is all the way from menarche, your first period, to perimenopause. And then we have perimenopause, which is a potentially long process. It can last from 2 to up to 10 years before actual menopause. And there's different phases to the process, which we'll talk about in a minute. But it's important to know this is a sequence of events, and there's different symptoms potentially that can be associated with those events. And then we have postmenopause, which begins after that 12 months that you haven't had a period, then the rest of your life is postmenopausal. So the sequence of events we can expect in perimenopause. First, we see low progesterone, and that's because you only make progesterone when you ovulate. And when we get into our late 30s and early 40s, we can start to have anovulatory cycles where we don't ovulate and then we don't make progesterone. And there are symptoms associated with that are distinct from the symptoms of the next two phases. And so what can happen next is that you have high estrogen. We think of menopause as a time of low hormones, but before our estrogen bottoms out, our ovaries really fluctuate their production, and we can have higher estrogen than we've ever had in our life. And I'll show you kind of what that looks like in a graph in a minute. And then finally, you get to that low estrogen phase. And so what this looks like graphically, you can see the red is estradiol. This is our most potent estrogen and our most abundant estrogen in our reproductive years. And then we have progesterone. Talk more about what each of these do later, but you can kind of see how in our late childhood, preteen years, we start to get some estrogen production, eventually enough to ovulate. When we ovulate, we start making progesterone. And you can see in our reproductive years, we have pretty consistent progesterone production, pretty consistent estrogen production. And then in that early stage of perimenopause, that's when we start to see those anovulatory cycles with the low progesterone. But you can see estrogen can go high and it can really fluctuate. And this is that roller coaster of perimenopause that people talk about. Hormones are really, really kind of all over the place, especially estrogen. And you can see here, this is the low progesterone and normal estrogen, but then you get to low progesterone and really fluctuating estrogen. And finally, you get to the low hormone state. And so what that kind of looks like on a timeline, if we start here at menopause, this is that line in the sand that occurs 12 months after your final menstrual period. And so this final phase of menopause, this fourth phase of menopause, is called late perimenopause. It's the final 12 months from your last menstrual period until menopause. And that is usually a state of low hormones. There might be a bump of estrogen every now and then, but not enough to menstruate. Prior to that, if we jump back to the beginning here, this could be in your late 30s, early 40s, you still are cycling regularly, but progesterone starts to get low. And there are symptoms associated with that are general, nonspecific, and because of that, are often ignored or misdiagnosed. We'll talk more about that in a minute. And then you start to get irregular cycles. So a full menstrual cycle is from one period to the next. It's an average of 28 days, but really for women can range anywhere from like 26 to 32. But for most women, when their hormones are in a good state, healthy balance, that timing is very regular. You have a 29-day cycle every month, or it just varies a couple of days. When you start to get variance by 7 days or more, that's when you're starting to get into that early stage of the menopausal transition. And then when you actually skip a period, so you have more than 60 days without bleeding, 60 days or more without bleeding, that's when you're kind of in that late perimenopausal transition. So you can see the amount of time that these phases last varies, and it can last a couple of years, or it can be a whole decade of transition. So what are the hormones here at play that we're talking about? We're talking about progesterone. Progesterone has a lot of roles in the body, but generally it's very calming. It also helps to sustain the uterine lining. We need it to sustain a pregnancy. But it's not just our uterus that needs progesterone. We have progesterone receptors all over our body, including in our brain. It's produced after ovulation and starts to decline in our mid to late 30s. Symptoms of low progesterone. Remember, this is a calming hormone. It affects our brain. And when we don't have enough of it, we can have trouble sleeping. It can cause hot flashes and night sweats. Low estrogen does that as well, but low progesterone can cause this. Mood disturbances like anxiety, depression, even forgetfulness, heart palpitations, migraines, and then heavy periods and painful periods. These can all be symptoms of low progesterone. You can imagine if you're a woman, you're in your late 30s or early 40s, if you go to many medical providers and report you're not sleeping much and you're anxious, you're not necessarily going to have your progesterone status investigated, but that could be why you're experiencing those symptoms. Then we have estrogen. Estrogen is it's a hormone. You think about it, its characteristics as being voluptuous and juicy. It's not just produced in our ovaries, it's also produced in our adrenal glands and in our fat. Production becomes less consistent in our 40s, and estrogen plays a lot of important roles. These sort of first three are some of that we think of as more classic roles of estrogen. It's responsible for the development of female sex characteristics. It thickens the uterine lining to get it ready for a pregnancy. It helps supports vaginal lubrication. But look at all these other things that it does. It promotes muscle growth and preserves bone density. It maintains urinary continence and skin elasticity, stimulates hair growth, sustains a normal body temperature. It helps us to be sensitive to insulin, which is super important. And then in that role, it also helps to maintain healthy cholesterol balance. And it also balances out cortisol, which cortisol is desensitizing to insulin. So this is all really important for metabolic health and long-term health. It controls our blood pressure, regulates appetite, regulates and adjusts levels of neurotransmitters, and it's neuroprotective. It promotes circulation in the brain. So if you just kind of look at these roles, you can understand the health risks and the symptoms that come with peri and postmenopause. When you don't have estrogen playing these roles, your body has to recalibrate and your risk of certain conditions increases. When estrogen is high and fluctuating, we don't have enough progesterone to balance that. These are symptoms that you can experience. So heavy, painful bleeding, flooding, even irritability, breast pain, and then even things like high histamine. Estrogen can elevate histamine, which is a neurotransmitter that can cause allergic symptoms. So you can start getting hives, things like nasal congestion, ringing in the ears, diarrhea, nausea, low blood pressure. These can all be symptoms that are symptoms of perimenopause because they're symptoms of high estrogen. Conversely, when we start to get to that low estrogen phase, that's when we get these classic symptoms of menopause, right? Hot flashes and night sweats, mood and sleep disturbance, thinning of vaginal and urethral tissue. Collectively, these symptoms are called the genitourinary symptoms of menopause. They can include dryness of that tissue and itching, pain, increased urinary frequency, incontinence, prolapse, and increased frequency of UTI, which can actually have cognitive impacts. We'll talk more about that later. Body aches and pains, and then changes in body composition. So abdominal weight gain, this in part is due to insulin desensitization, but also it's our body, we're making estrogen in our fat now. And so our body's going to hold on to that more tenaciously. We also can lose lean muscle mass and bone density. So these are things to be aware of that we can mitigate with lifestyle. A lot of this can be mitigated with lifestyle, so don't be daunted. But there are other changes that come along with low hormone status that are also associated with aging, things, changes in our skin, our hair, our teeth, our vision, our hearing, and our mind. So lots of changes occurring as a result of that low hormone state. Can you test to see if you're in menopause or a perimenopause? There's not a test that will diagnose menopause, just as we don't diagnose puberty. Menopause isn't a disease that needs to be diagnosed, but women often feel like it would be helpful to know if that's what's happening. And the truth is that collecting one blood sample isn't going to tell you that, right? If you remember that graph that was going up and down, you could catch a hormone at a low state, but that doesn't mean it's not going to be at a high state later. Even when we're premenopausal, our hormones fluctuate. And so it's okay to use testing, but it's important to know what kind of information that's going to give you. So one thing you can test is your FSH. This is a hormone that comes from your brain and talks to your ovaries. When it gets high, so kind of above 30, it's safe to say that you may become menopausal within 3 years. So not sure how helpful that is. You can also interpret a lot of that from the symptoms you're experiencing. You can look in that early perimenopausal phase. It can be helpful to look at progesterone and estrogen and see if you are in that state of low progesterone production. Again, you're just catching a moment in time. You might have high progesterone production that next menstrual cycle, but sometimes it's helpful just to look at that and interpret those results in context of other symptoms. There are often a lot of women ask me about urine tests for hormones, and so I just wanted to mention that. To my mind, the most valuable use of those is to look at how your body is detoxifying from hormones. This can help if you're worried about using menopausal hormonal therapy and you want to see how your body is detoxifying from hormones. But the best way to know what's happening with your body in terms of ovulation is symptothermic tracking, and that's it's almost free. After you buy a thermometer, you take your temperature every morning, you monitor cervical mucus and other symptoms like how you feel mentally, emotionally, and physically. And that is really the best way to understand whether you're ovulating. You can tell whether you're ovulating just by doing that. And if you see that you're not ovulating, you're making progesterone, and you put it together with symptoms and your age, you can start to have a good sense of where you are on that timeline. So now that we understand more about menopause and perimenopause, how can we smooth out that roller coaster? We know we're in for some changes, but it doesn't have to be hellish, right? We have a lot of tools that we can use, and the first tools are going to be lifestyle based. So the first thing to think about is nourishing your body. And I like to kind of categorize this in a few different ways. One is to eat for the health of your ovaries. Your ovaries are really impacted by the health of the mitochondria in the cells. Those are the little energy powerhouses. And those are heavily impacted by oxidative stress, which is essentially just oxidation is like a byproduct of normal physiological processes in your body, but also that can be increased by oxidative stress from outside, like pollutants, stress, things like that. So it's important when you're eating, you can use food to both reduce oxidative stress by avoiding inflammatory foods, but also give your body antioxidants. So this advice is not super complicated. Avoid and reduce inflammatory foods, which are highly processed. This includes most seed oils, most foods with added sugar, alcohol. And then conversely, eat lots of colorful fruits and veggies and herbs. These all have antioxidants in them. Seeds, nuts, and fish also are really good for that oxidative stress component. Another really important way to think about eating for hormone health is to eat for balanced blood sugar. Remember that as our estrogen declines, we get less insulin sensitive. And insulin is a whole different topic that I've done a talk on, but it can be super problematic for a number of reasons. It's very inflammatory, as is elevated blood sugar. So it's really important to eat for balanced blood sugar, avoiding added sugars. And then a really simple rule of thumb is whenever you eat a carbohydrate, even if it's a healthy one like a fruit or a starchy vegetable or a whole grain or a piece of cake, eat it with a protein, a fat, and or a fiber. And that's going to slow down the breakdown of that sugar, and it makes a big difference. So if you're eating an apple, have it with peanut butter. If you're eating a piece of cake, maybe have it as a dessert following a meal versus all by itself. And that will help with balancing your blood sugar. Another food category to think about for hormonal health is phytoestrogens. These are estrogen-like molecules in plants, primarily soy is a good source of them. They're helpful for both high estrogen and low estrogen because they bind to those estrogen receptors and they can prevent more potent forms of estrogen from binding. So that's if you have high estrogen, they can kind of weaken the effect of that. And then if you have low estrogen, they bind to the estrogen receptors and have a weaker estrogenic effect. So incorporating more soy into your diet can be helpful. Soy is a problematic food when it's heavily processed or heavily sprayed. So ideally get organic. And these are types of more whole forms of soy. And then your microbiome, and I'm referring specifically to your gut microbiome here. Benefits of a healthy gut microbiome, and this is the ecosystem inside our digestive tract, include mental stamina, bone density, healthy body composition, improved sleep, reduced inflammation, and improved energy. These are all kind of counterparts to some of the symptoms and health risks of low hormone state. So you can see that having a healthy microbiome can be important for countering the symptoms and risks of menopause. How do you do that? Well, eat a whole foods diet, eat a wide variety of plant fibers, avoid refined and processed foods, artificial sweeteners, and use antibiotics judiciously. So you can see when it comes to diet, it's not rocket science. You don't have to follow a specific diet, but in general, if you're sticking to whole foods, you're getting a wide variety of plant foods and you're avoiding added sugars, you're going to be doing a lot of good for your overall health and your hormone health. Another really important thing to think about when it comes, it's not purely lifestyle, but having a healthy daily bowel movement. So many people in general overlook the importance of that. And it's just part of my job as a physician to remind people that your colon is a really important organ of detoxification. And when your liver processes hormones, it dumps the hormone metabolites into your colon, expecting they're going to be removed from the body. And when they're not, they can recirculate and cause problems. So really important for hormone health, just to make sure you're having a daily, well-formed bowel movement. Exercise counters a lot of symptoms of perimenopause as well as those postmenopausal health risks. Can reduce hot flashes, mitigate those body composition changes, protect your heart function, your bone health, and your cognition. These are the big three things we're worried about after menopause, and exercise helps with all of them. It also helps with mood and libido. So win. But how you exercise changes after menopause because our muscles, we have less estrogen and less testosterone, so our muscles are going to be less responsive. So it's still important to combine cardio and strength as well as flexibility and balance, especially as we age. But the way we do our cardio and our strength is different. It's important to or recommended to do sprint interval training versus just long, slow distances when you do your cardio. And then for strength, it's really helpful in order to actually build and maintain muscle mass postmenopausally to lift heavy stuff. So 80% of your max, this is something to work with a trainer on. Building up to working 80% of your max on just a few reps is going to be more successful at building and maintaining muscle mass than multiple rounds of light weights. And then, of course, flexibility and balance. So falls and fractures are a big health risk as we age. And when we work on our flexibility and balance, we mitigate that. Sleep Super important for reducing oxidative stress, as we talked about being really important for the ovaries, but sleep is more challenging in those peri and postmenopausal years due to low hormone levels. So what can you do to support sleep in that low hormone state? Well, behavior and environment play a really big role. Reducing alcohol and avoiding it 30 minutes before bed, avoiding caffeine after 2. Having an earlier dinner, like 2 to 3 hours before you lie down, is helpful. Turning off screens a couple hours, avoiding that blue light, keeping your room cool and dark like a cave. Having an evening wind down practice. This is something that I recommend to a lot of my patients. We do this with our kids. We put our toddlers to bed in like a really nice, gradual way. But when we put ourselves to bed, often we kind of go, and then lie down and expect ourselves to fall asleep. So having an evening wind down ritual for yourself can be really helpful. Journaling before bed to take things out of your mind. And then we also in naturopathic medicine have a lot of other options for sleep support that are not behavioral. Stress makes everything worse, including menopause. So it's important to, especially as you become perimenopausal, to get real about your boundaries, about what you say yes to, and reduce stress where you can. And boundaries and saying no is one of the best ways to reduce stress. And then there's going to be things you can't say no to. So it's important to mitigate those stressors by investing in time that puts you in a state of low stress. So massage, breath work, yoga, acupuncture, arts and crafts, even things like music, dancing, gardening, all of these things can put you in a low stress state and are really, really important investments in your health. It's not just like a leisure activity. It's really important for your health. And then reframing stressors, including the menopausal transition. And we'll talk about how we can reframe the kind of typical narrative around menopause in just a minute. One final piece of lifestyle around menopause is connection. In general, our connections can become more tenuous and we have fewer connections as we age, and works counter to our health. Loneliness is actually as great a risk factor for heart disease as smoking. And then more than diet, exercise, how much money you have in your bank account, your cholesterol levels, or even your genes, it's your relationships that matter most when it comes to being happier and healthier in midlife and into old age. And this is a study, I believe out of Harvard, I can't remember, but it came out a couple of years ago and just really, really profound. Your relationships matter. So investing in friendships is really important at this time in our lives. Okay, what can we do beyond lifestyle for symptom support? So my big message for you here is that you don't have to suffer. If you put in place these lifestyle measures and you're still symptomatic, which happens, we have lots of tools that we can use to help minimize the symptoms. And I'll go through some of these, most of these in just a minute. Nutraceuticals, so things like vitamins, minerals. We have a lot of botanicals that we can use. We have physical therapies like massage, acupuncture, and I won't talk so much about those today, but I wanted to mention them, give them an honorable mention. And then menopausal hormone therapy, which I'll go into more detail in just a minute. So nutraceuticals, these are some of the most common I use for my perimenopausal patients. A high quality multivitamin. We don't often get enough nutrition in our diet, and these nutrients are really important for things like liver detoxification and blood sugar balance. And so a high quality multivitamin can be really helpful. And then getting more specific, vitamin C can help with progesterone production. Magnesium glycinate is one of my most commonly prescribed supplements. It's super helpful for sleep, anxiety, muscle tension, and blood sugar balance. Vitamin D, again, one of my most commonly prescribed supplements, really important for deep sleep, hormones, bone health, immune function. And we, in theory, could make it from sunlight, but at this latitude in Washington State, we typically don't get enough direct sunlight to make optimal levels of vitamin D. So when I test my patients here in Washington State, 9 out of 10 are going to have suboptimal vitamin D if they're not supplementing, and it can make a really big difference to so many aspects of your health. Omega-3 is an anti-inflammatory fatty acid that you can get from fatty fish, and then probiotics can help with that gut microbiome, as can prebiotics, which feed the probiotics. So then we get to botanicals, and this is just a sample, more just to kind of show you the range of options that we have. I don't recommend bringing on board botanicals without talking to someone who's used to working with them, because there's a lot of them, there's subtle differences between them, and it's important to kind of incorporate them into an overall strategy for your health versus just kind of taking random supplements. But we have some really great tools for hormone balancing. These are 2 that I use a lot that are really, really effective. Adaptogens help us respond to stress, and these are some of the most commonly used ones, but we have a lot of them. Calming nervines, if you're having trouble sleeping, we have botanical support for that. And then support for the liver, support for that hormone detoxification can be helpful as well, just depending on what's going on with you. Finally, menopausal hormone therapy, and this is abbreviated as MHT, and it's a shift away from a term that you may have heard before, hormone replacement therapy, or HRT. And that shift has happened because we're recognizing now as a medical community that we're not replacing a hormone deficiency. Menopause is not a disease. It's not a state of hormone deficiency. That's not to say that women might not feel better if they had supplemental hormone. It's just like saying a headache is not an ibuprofen deficiency, but ibuprofen can help with a headache, right? And so it's just a semantics. The semantics is important in health. So the North American Menopause Society, and this, a background of this is that in the 2000s, as a medical community, we got scared away from using menopausal hormone therapy. And that's a more complex conversation. But what I would like you to take away from this presentation is that if you don't have a contraindication, like a history of breast cancer or cardiovascular disease, it may be an option for you if you're suffering. It may be a safe and effective option. And there's really an optimal window to bring it on board. So for women who are younger than 60 and who are within 10 years of the onset of their menopause, they don't have contraindications, the benefit risk ratio is favorable. To treat bothersome vasomotor symptoms, that's going to be the hot flashes and night sweats, and for prevention of bone loss. So just to kind of repeat that in more layman's terms, if you are younger than 60, or if it's been 10 years or less, fewer, since you became menopausal, you don't have contraindications, menopausal hormone therapy can be helpful for hot flashes, night sweats, and prevention of bone loss. Conversely, if you're older than 60, or you haven't, or it's been more than 10 years since menopause, then that risk benefit ratio doesn't work out. And one of the main reasons is because the arteries, in the absence of estrogen, can become more stiff and brittle. And then when you bring on board estrogen, which can be, depending on how it's delivered, can promote clots, you end up increasing the risk of stroke. This doesn't mean, and this is a subtlety, it doesn't mean that if you've been using menopausal hormone therapy, estrogen and progesterone since you were like 52 and now you're 60, it doesn't mean you have to stop, because you've had that estrogen supporting your blood vessels that whole time. So this is a complex conversation beyond the scope of this talk. There's different delivery methods of hormones, oral versus transdermal versus vaginal, that all have different risks. If you have a uterus or you don't, that changes what kind of hormones you should be taking. And then there's the whole bioidentical versus non-bioidentical conversation as well. Those are all separate conversations to have with a knowledgeable provider. The takeaway is to have those conversations. Don't be afraid to have those conversations. Don't assume that it's not safe to take hormones, to use hormones in this transitional period and beyond. So speaking of beyond menopause, what comes next? Well, lots of things happen. This is a third to half of a woman's life. And this quote from Oprah, she's done a lot to bring menopause more to the forefront. She says, so many women I've talked to see menopause as an ending, but I've discovered this is your moment to reinvent yourself after years of focusing on the needs of everyone else. It's your opportunity to get clear about what matters to you and then to pursue that with all of your energy, time, and talent. And here's a quote from one of my mentors, Dr. Aviva Ram. The idea that this natural shift in our hormones signals some kind of slowdown is simply ludicrous. Internalizing the message that we are irrelevant, dried up, or past our prime holds us down and keeps us from claiming our authority and strength. I invite you to reject that noise entirely. By the time we reach menopause, we're smarter, sexier, and more badass than ever, with more wisdom, maturity, and life experience, and often a whole new level of freedom in our lives that can make us more productive, energetic, and downright sexy. Own your strength, you've earned it. So this is part of reframing that menopausal transition. And I love this particular slide because it helps to understand and reframe why menopause even happens. Menopause is relatively unique in the animal kingdom. It only happens to humans and to a couple species of whale and maybe an insect. Not to our closest mammal relatives. And by what I mean by that is that most animals do not significantly outlive their reproductive years. It can happen. You can get a really old cat, but it doesn't happen as a matter of routine, right? That happens only in humans and a couple species of whales, like I said, and maybe an insect. So why? Things don't happen in nature without a good reason. And one hypothesis is the grandmother hypothesis, that grandmothers actually enable their offspring to have more children. And so in that way, they promote their own DNA, and that adaptation ends up getting incorporated into the species. And we see this in hunter-gatherer tribes that have been studied, that postmenopausal women or women who are beyond their reproductive years, they consume fewer calories than they collect, and they help their offspring to actually be able to have more children and raise more children. So in this way, menopause may actually be an evolutionary adaptation that's contributed to our success as a human species. And one story I like to tell about this is the story of Genghis Khan, who you may have heard of. About 0.5% of humans on the planet have some of his DNA. That's 16 million people. And when he was a little boy, his father was poisoned and his whole family was expelled and kind of sent to their fate on the isolated steppes of Mongolia. And they were with their mom, who was apparently beyond her reproductive years, or she stopped reproducing, maybe because she didn't have a partner. But the point is that she had the capacity to take care of and support and help her children and keep them alive. And because of that, he was able to very successfully spread his DNA. He ended up conquering a lot of the world at the time and spread his DNA. And so, hundreds of, or you think even thousands of years later, he's got millions of ancestors. So that's a testament to the evolutionary success of his family that was enabled by his mother. Okay, so it's not all, rah, go menopause. There are symptoms and health risks associated with menopause and being postmenopausal. The hormonal fluctuations that we saw in that graph will eventually stabilize. And with that, a lot of the symptoms that I talked about will go away. In fact, a lot of women report feeling a postmenopausal zest. There's been some studies that show that over 50% of women interviewed said they felt better postmenopausally than they did in their 20s and 30s. And painful hormonal conditions will go away, like endometriosis and fibroids. So all of that is something potentially to look forward to. However, there are symptoms that will persist because of that low hormone state. Those are going to be things like vaginal dryness, painful sex, and those changes in body composition that can be somewhat mitigated with lifestyle. Then we have increased health risks, and each of these can be mitigated with lifestyle, and that's why that perimenopausal window is such a critical window for health, because after menopause, we really do have we're facing a different health landscape. We're going to have increased risk of cardiovascular disease and osteoporosis, cognitive disorders like dementia, and then also urinary tract infections, which may not sound like a huge deal, but like I said, they can lead to cognitive disorders and then dementia, because oftentimes changes in mental status are one of the first signs of a urinary tract infection in older women. So I put that here as a health risk versus just a bothersome symptom. So the takeaway from that is that these can all be mitigated with lifestyle. So, but also that once you kind of are done with menopause, you're not done with thinking about your health. There's more to continue thinking about and being cognizant of. So takeaways from this talks in summary. Remember that perimenopause is a sequence of events that can begin in your late 30s, early 40s. So you're not imagining things if you start to feel like not yourself around that age. There can be hormonal changes happening, and that's normal. Lifestyle has a big impact on how we experience perimenopause. You don't have to suffer. There's a lot of things you can do. Our health risks change after menopause, but they can be meaningfully reduced with lifestyle changes. And our postmenopausal years can be rewarding, full of purpose, and some of the best of our lives. So I'm told. Let's do it. If you want to take a deeper dive into this information, I'm going to give you a couple different resources. First of all, working with a provider, an integrative provider, I'll kind of talk you through what that might look like. In my practice, when I'm working with women, I spend a lot of time. Our first visit is 75 minutes. We take a deep dive into your health history and your current lifestyle. We might use testing judiciously, just depending on budget and depending on if we think the information we gain is going to change the treatment. Interpretation of that symptothermic charting that I talked about. So I teach my patients to do that charting and help them interpret it, and then give them personalized recommendations for lifestyle modifications, supplements, and potentially menopausal hormone therapy. And I just included this little pyramid here because I often talk about that pyramid of therapeutic order that we can choose interventions from. The higher up the pyramid we get, oftentimes the more invasive, sometimes the more expensive, and the more sort of targeted to particular symptoms that we get. There's no good or bad part of the pyramid, but it is important to always work at that lifestyle level, even if you're using therapies higher up that order. So all that to say, I don't ever just give my patients a prescription for hormones. I'm always working at that lifestyle level as well. And then another, I think, important part of working with a provider through this phase is just having that accountability support for these lifestyle changes, and then validation. I have a lot of patients, and I'm going to share a testimonial with you in just a minute, who go to their primary care providers and are kind of just told like, this is, just kind of suck it up, or you're imagining things if they're younger. So just that validation that, yes, things are changing and there are things you can do about that. And so this is a testimonial from a patient of mine who gave me permission to share this. In fact, she wrote this as part of a email we sent out marketing a women's health and hormone retreat that I'm about to host. And I wanted to share this with you because I think it encapsulates the benefit of working with an integrative provider on this, on menopause, perimenopause. She says, perimenopause didn't just impact my life, it melted me down. And I mean that literally. I was on internal fire. Night sweats would soak my sheets, and daily hot flashes would leave me wringing wet at the most inopportune moments. I was having heart palpitations. I never had a weight problem, but all of a sudden I had a totally not adorable spare tire around my middle. My brain felt foggy, and I was so exhausted that even after a full night's rest, I needed a nap at 3 p.m. Worst of all, I was irritated all of the time. Everything bothered me, and I had multiple occasions where my normally calm demeanor erupted into a furious, foaming at the mouth persona that left me overwhelmed and ashamed. I didn't just feel like I'd lost myself. I felt like I was losing my mind. What was happening to me? My general practitioner told me I was in perimenopause and I just have to deal with this fresh hell. WTF. Out of desperation, I started Googling, and thankfully I found Dr. Kellie Moore. Dr. Moore helped me address my hormonal imbalance based on blood tests and prescriptions that were personalized to me, and she taught me a new way to eat and take care of myself. Within weeks, I started to feel like myself again. Night sweat stopped completely. My energy is up, and I feel much less irritation. You do not have to feel like you're losing your mind. Information is powerful. And I really do believe I'm really passionate about sharing information. That's why I do these talks, but also why I'm doing this upcoming retreat on women's health and hormones. This is a 3-day retreat composed of 4 different workshops that basically have all the information I wish we learned, in sex ed or high school biology or from our doctors, but we just don't learn this information. And it's information that all women should know. I'm hosting it in the Mount Howell Valley in Winthrop, Washington, up east of Bellingham, so a little ways from Vancouver, but not crazy far. October 27th through 29th, I'm hosting it with my friend and colleague who owns this yoga studio. And these are the topics that we're going to be covering. Period power, I'm going to spend 2 hours going through the menstrual cycle in detail, which is helpful to understand even if you're no longer menstruating. And then I'm super excited to talk about female anatomy. There's a lot of information that is relatively recent to science because of female scientists and female doctors. So super excited to share that information. And then a 2-hour workshop on navigating menopause, which will cover some of what we've talked about today and more. And then a whole 2 hours separate of to talk about life after menopause. So if you'd like to work with me, this is how you can schedule with me at Ripple. You'll get a PDF of these slides too for your reference. If you'd like to stay connected, drop your email in the chat, and we have a couple minutes for Q&A. Thanks so much for coming this evening. I'm sorry about the technological difficulties. I hope you're still able to get some good information from the talk. And then Zoe, I'm not sure how you do the Q&A.
Yeah, so just I want to invite anybody who wants to, if you want to turn on your mic and ask a question, go ahead, or go ahead and if you have a question, type it in the chat. We have a couple minutes, we can get through a few.
Hi, I have a question. I think you mostly answered it when you explained that estrogen can spike, which is something I did not know. First of all, thank you for the presentation. I'm proudly perimenopausal, and I try to educate myself as well as possible about what's going on with my body, but I didn't know about that spike. And I've been frustrated because both my PCP and my naturopath, I see another naturopath in Washougal, won't prescribe estrogen for me. I'm on progesterone. I haven't gone a year without a cycle. I've gone 8 months for the last 3 years. 8 months cycle, 8 months cycle, 8 months cycle. It's very frustrating. And the progesterone was very helpful with hot flashes until I had 2 back-to-back viral infections in August and early September, and was on antibiotics, and then was on Paxlovid. And they're back with a vengeance. So is the reason that neither of these amazing female doctors, I want to shout out to female doctors, shout out to naturopaths, and shout outs to DOs. I always look for DOs, as a PCP as well. And I just find that they're a bit more open to alternative options. But is the reason why no one is going to prescribe estrogen and try to help me further with the hot flashes because I'm not yet technically in menopause?
Yeah, that is the reason, because you could potentially, I mean, it sounds like you're likely, if we look up in that this little graph, potentially, keep thinking you're in this last year before menopause, but then you keep having that other menstrual cycle and starting the clock all over. So you could, we don't know. There's no way really of knowing if you're going to have one of these big estrogen spikes, and then that could potentially just be more estrogen than is safe. I will say we don't know a lot about the safety, and potentially there's forms of estrogen that or doses, that may or may not be safe. But that's why kind of the standard is to avoid giving estrogen at that time. Yeah. But I will say, I mean, as you know, from working with a naturopath, and kind of just to reiterate, as well as the menopausal hormone therapy, we have a whole sort of layer of different types of tools that we can use. So there's really great botanicals, nutraceuticals, lifestyle that can help with hot flashes. So that would be a conversation hopefully you're having with your naturopath.
Thank you. I'm trying to do all the things, like fewer carbs, not so much caffeine, etc. Nothing is having an impact, but I appreciate the answer. At least now I know why.
Yeah.
Hi, Kelly. I had a question. Can you tell me what the difference is between hormone therapy and birth control pill in terms of the benefits and symptom reduction that you might get with one versus the other?
Yeah, so there's one main difference, and that's dose. The birth control is going to be a much higher dose than menopausal hormone therapy. You're not trying to put the body in a position where it could menstruate, essentially. Although when you menstruate on a birth control pill, it's not true menstruation. So the dose is a lot higher, and then the form is oral, right? Usually, yeah, you said birth control pill. So yes, it's oral. And that carries a whole different category of risks because it has to pass through the liver than something like transdermal, or transvaginal, which can also be used for birth control, but are also common forms of menopausal hormone therapy delivery. So when you deliver a hormone transdermally or transvaginally, you skip the liver and you end up reducing very significantly the risk of clotting that comes with estrogen. And so that's one of the differences. And then one of the final differences is that bioidentical, you can have oral contraceptives don't contain bioidentical hormones, but something like an estradiol patch is going to be bioidentical. And that just means, it doesn't mean it's more natural. It's all synthetic, but it is almost exactly the same chemical structure as your hormones versus something that is non-bioidentical is not going to be the same chemical structures, but it is still going to bind to that receptor. But there is a chemical difference that may or may not impact you. Does that help?
Yes, thank you.
Any other questions? Peek at the.
I don't see anything in the chat. You have some people drop their emails and just thank yous for all the great information.
Awesome.
Yeah. So if there's, oh, go ahead.
I have a quick question for you. This is great information. I just like the other lady, I've navigated and doing my research and trying to do my homework, but I'm glad to know that there is no affirmative testing, so to speak, because I've thrown a lot of money at testing. Probably, a year ago, I thought for sure I'm hitting perimenopause because I had one of those losing my mind moments. Like I'm angry, I'm hostile, I don't know why. So, and I have a high family history of breast and ovarian cancer. So I did an intervaginal ultrasound. And the technician told me I was still fertile myrtle, which was great. But here we are, 12 months calendar year later, and I've missed my period 4 months in a row now. So trying to determine if I'm early perimenopause or end perimenopause, I guess that's kind of what I'm trying to figure out. And my PCP just keeps doing blood work. I just did blood work 2 days ago and they took 12 vials of blood. I don't know what all she tested for, and my symptoms, like you said, that big fluctuation. I made the assumption that when you're in perimenopause or menopause, the symptoms are continual. And I know everyone's different. Like I experience the hot flash. It comes and goes pretty quick, not the sweating or anything. So I've been seeking out natural remedies and stuff. The one thing, go figure, that works or remedies my hot flashes is coconut water. And if I don't drink a coconut water, if I go a day without, then I have a huge influx of what we would call a hot flash. So I know everybody's body's different, and we obviously have deficiencies or needs for whatever. Is it possible for somebody to completely, not remedy, but to keep your body in a healthy state using food, homeopathic methods instead of prescriptive?
Is it possible to keep your body healthy? Yes, using food and natural, sort of like natural botanical supplements, things like that, versus a medication. It really is, like you said, it just depends on what exactly is happening. But always, I do encourage people to start with lifestyle which is food. I mean, food is medicine, and conversely, it can be a poison. Just food-like substances, processed foods are hugely problematic. And so the short answer is yes, when you really invest in your diet, you're going to be supporting your health and potentially minimizing the need for other medical interventions.
Yeah, because I'm just worried about the long term, obviously the osteoporosis and the long term effects of not doing something now. I mean, obviously it's how diligent you are, but I just started to notice like the IBS is kicking in. There's days I feel like I can't remember a thing, and then other days, oh yeah, my memory is really sharp. But silly things like I learned that a cucumber a day has the full allotted amount of all B vitamins that women need. So, medicinal things like that. Well, just using what's provided for us to keep ourselves, in a healthy state.
Yeah.
Because, my mom for years said, don't ever go on hormones. Don't ever go on hormones. It was like this awful thing that previous generations or my mom's generation was anti. But looking back, she had cardiovascular disease. She also had Graves' disease. They destroyed her thyroid. I mean, she had all these complications, inflammation like crazy, probably related because she didn't treat it.
Yeah, I think a takeaway from that anecdote is just not to be scared of hormones just in and of themselves, right? There's a lot more nuance, and a low hormone state for too long in a woman's life comes with additional health risks. So it's important to have a really in-depth conversation with a provider and not just assume that hormones aren't safe for you. They may not be, but they might be. So yeah.
So there's really no way to determine then how far into perimenopause I am, whether I'm beginning or end.
The FSH. If you have a high FSH, it's likely that you'll be menopausal within 3 years. That's the kind of the closest.
Okay.
We have. Yeah, but there's a lot in between then, and doing your learning how to do that symptothermic charting that will tell you whether or not you're ovulating, and that will give you some kind of information. So I really encourage, if you have questions about what's going on with you in terms of your cycle, learning how to do that symptothermic charting is really helpful. Yeah.
Fantastic. Well, and thank you so much. It's nice to know that I didn't even know that there were physicians out there that, were detailed or like specifically treated, menopause. I didn't realize there was somebody I could go to besides a PCP or, a GP. So thank you so much for your time.
Yeah, you're welcome. Okay. Yeah, I think we're done with time.
Okay, yeah, we are. We're actually over our time, so I want to thank you for staying and thank everyone for participating. Just quickly, there is a recording. It'll probably be out in a few days. We do closed captioning, so we need some time to do that. But then it will be put out on Fort Vancouver's Regional Library's YouTube page. So again, thank you so much, everyone, for attending. Thank you, Kelly, and thank you, Ripple.
Yeah, thanks.
Good night, everyone.
Zoe, can I get the printout of the chat from you? Is that something that you do?
Yes, I can get, I believe so. I can get, yes, let me take a look here. Absolutely.